Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Samatinos, and super excited to have you here. I'll tell you why, because we're bringing some really exciting conversations with fantastic leaders that are painstakingly shaping the future of healthcare. And we're really passionate around healthcare innovation and adoption and things around access and leadership. And if it's your first time tuning in, let me just take a quick step back before we dig in for our guest. We're a healthcare innovation company, and we're focused on bringing real stories of innovation to life. And what does that mean? We highlight people that are in the trenches, getting stuff done, and giving them the platform to be able to share their stories with the world. And we've got just an amazing action-packed year. If you haven't checked out any of the historical episodes, make sure that you hit the subscribe button now so that any new interviews that come out go right to your inbox. And as part of our commitment to keeping you updated with the latest and greatest, we have a very special guest today, Bridgette Clifton, the Vice President of Operations for the Longevity Health Plan in North Carolina. She's got a very, very unique set of combination of skills. She's a clinician, also an operator, and she's just a dynamic leader that's committed to driving innovation and quality within our space. Now, she possesses I'll say, a very profound understanding for adult and geriatric care. She's a certified professional in healthcare quality, and she's really making a noteworthy contribution in optimizing patient care and outcomes. And her commitment isn't just within healthcare, it extends beyond her professional roles, as noted within her volunteer work at the Family Abuse Services of Alamance County. Bridgette firmly believes that you got to give back to the community, demonstrating what it really means to be a leader. It involves service, and her passion, dedication, and sort of her multitude of talents personify the word innovation. And we're thrilled that she's going to be able to sort of share her story, her insights, and some of her experiences within sort of her journey. So, Bridgette, great to have you on the show. Welcome.
Thank you for having me, Michael.
So let's start out. Let's dig in a little bit of just sort of your story. What got you so enamored sort of within the geriatric space? Was that something that you knew early on? Tell us a little bit about that.
No, I didn't know geriatrics would be it early on. I knew I would be in healthcare. People ask me how I ended up in healthcare. I don't know. I knew I wanted to be a nurse, and I never questioned it. So when I was in high school, we had a great medical careers program. So I'm very, very pro occupational courses and career and technical programs in high school because that's how I got my start. And so I had my CNA by the time I graduated high school and went to work in the emergency department. And I really thought emergency medicine was where I wanted to be. I loved it. I loved the pace and the excitement and having to think on your feet. And I worked in the ER as an ER tech through nursing school, went to nursing school, finished nursing school, came out, went straight back to the ER, thought this is where I'm going to be forever. And then you start seeing the population that comes in the ER, and it is certainly not like ER on TV. You have those cases, but those are, a couple times a month, depending on where you're in a facility. A lot of it is, it's a safety net for those who don't have access to primary care. And that was the issue that I was seeing, and that was the issue we were dealing with in the ER is we were kind of the first stop and the last stop for everybody. And so we have this influx coming in the door, but then we've got, maxed out capacity hospitals. And so they could get them out of the ER. And so after a couple of years in the ER, I thought, the only way to fix this problem is to get ahead of it. Let's go upstream, see if we can address these access to care issues and primary care issues. We were getting referrals from primary care offices for things that they should have been taken care of. But the ones that broke my heart were the long-term care residents that we would get. And we would get, the patient that fell and no injuries, but there was no one in the nursing home to assess them. So they would call EMS. They'd load this, elderly patient on a stretcher, and about, we've got skin cares and bruising now that they've had from this EMS ride. They'd come into the ER. They'd lay on this stretcher. They would miss their medications. They'd miss their meal times usually. Our physicians would assess them, maybe an x-ray that quite frankly could have been done in the nursing facility. And then when everything was fine, we'd send them back and they'd have to ride back. And, depending on other chronic conditions that might have induced delirium, it was a horrible situation. Um, and for personal reasons, I realized at the end of a 12-hour shift in the ER, I was spent. At some
Yeah.
point, I wanted to start a family, and I wanted a life outside of my job. And so I went back to school. Went back to school to be a nurse practitioner, um, finished my training, really thought I'd end up in primary care. That was what I wanted to do, was primary care. Was presented an amazing opportunity at a cardiology office. It was a private practice. So I took that position. Best decision I made. And the cardiologist I worked for really also believed in this, right place mindset of treating patients where they are. So we would treat patients in the office that a lot of people would have admitted, and a lot of practitioners would have admitted to the hospital. And what got me with the stories with these patients was the reason some of them didn't want to be admitted to the hospital. I mean, we would tell them, we
Yeah.
really think, you have a heart failure exacerbation that we could better treat in the hospital. And their reasons were, I don't have anyone to take care of my wife. She depends on me. Or I don't have anybody to take care of my dog. I'm not staying in the hospital all night. And as healthcare providers, we have to care about those things. If we really want them to be compliant, we have to care about all of their social dynamics and all of the people that they're caring for. So we'd see patients in the office every day, and we'd weigh them, and we would reassess them, and we adjust their medications if that's what it took to keep them out of the hospital. And then my life took a whole nother turn personally, and I ended up in the long-term care setting. So now I'm in the long-term care setting as a primary care provider. And in that moment, that was when I came home every day, and I told my spouse at the time, I said, this is the best job ever. I get to spend all day with these long-term care residents. I get to meet their families. I get to hear their stories. I get to learn their backgrounds. I get to find out what's important to them. I'm making medical decisions based on what they want their life to look like, not just, a 15-minute snapshot in the office. This is what the clinical practice guidelines say. This is what I'm going to put you on. We had conversations, and we said, you might be in the final 5 years of your life. What do you want that to look like? And let's tailor your plan to look like that. Um,
Were
best.
at the time, were any of your colleagues going that deep and getting as connected to their patients? Were they able to hear their patients open up as much to them as they were to you? And did you think that that was something that was either like down to individual skill, or was that a gift that you just kind of had within you?
I think if you're attracted to this field, you have a little bit of that in you. Um, but I think, and I'm gonna be honest, it is a skill I learned later in life. And I'll give you, if you want, a very specific story.
Please.
So I used to be very closed off. I will say that. I was very black and white. I didn't want my professional and personal life to mix. I think part of it, I was pretty young when I got into healthcare. And so
Mhm.
I felt like I needed, in order to gain credibility, I needed to keep my personal issues aside. So when I worked in cardiology, I didn't want my patients to know anything about my family. I had a young child. And I remember there was one day I had to call out because my daughter was sick and I had anybody to take care of her. And I had, all my patients scheduled for that day had to be rescheduled if someone else, one of our other providers in the office didn't see them. And so a couple of days later, I'm seeing one of the patients who had to be rescheduled. And she didn't mind. It was no big deal to her to be rescheduled. And she asked me how my daughter was doing. And to say I was upset that the office had shared that with her. And she genuinely cared. She wasn't upset. She didn't mind. She really wanted to know. But at that point in my life, I had a very firm boundary there. Well, fast forward a few years later when I started working in long-term care. Soon after I started working in this facility, I was pregnant with my second daughter. So I still very closed off, I don't want anybody to know anything about my personal life, that I was a mom, nothing. But you can't really hide being pregnant. So at a certain point in my pregnancy, everybody sees that I'm pregnant. And so I had a particular patient who was actually very young for a long-term care resident, but she had had a massive stroke. And so I had been taking care of her for a while. Actually, kind of small world story. I had taken care of her at a different facility. She was hospitalized. I then transferred facilities just because of
Mhm.
geography. And when she was discharged, she comes to this facility. She cannot make any of her decisions on her own. I mean, she is really in the final stages of her life. And her daughter is listed as her decision maker. And I had been trying, even at the previous facility, I'd been trying to reach this daughter and never could get her on the phone, never could get her to engage, to have these conversations about, this is the reality. This is, what
Yeah.
this trajectory looks like. Like we're looking at months, we're not looking at years. And these were conversations I needed to have. And so we tend to be judgmental and we tend to write stories. And I'm thinking, how can this daughter be so disengaged? Why doesn't she want to talk about this? So I finally get her on the phone one day and she tells me that she had just had a baby. And she said, so, I've been dealing with that, but I promise I'll be up there next week. So she comes up there next week and she walks in and I'm pregnant. So she sees that. And so instantly there was at least a softening. I know she just had a baby. She sees that I'm a mother, or at least going to be, and just making conversation. I asked her, I said, so who's watching the baby while you're here with me? And she said, well, she's in the NICU. She was actually born like 2 months premature. And she said, so as soon as we have this conversation, I've got to get back. And in that moment, that was when I realized that in all my judgment of this woman and why was she not here with her mom? I realized this one human being is dealing with, she has a child that is hanging on to life, and she has a mother that's hanging on to life, and she's got doctors in the NICU saying, we're going to do everything. And then she has me over here saying, we need to stop doing everything. And no human can deal with that. We're
Yeah.
not meant to deal with that much. And she was doing most of
Yeah.
this on her own. And, but in that moment, we were able to have that personal conversation and have that connection. And we spent probably the first 30 minutes of that conversation talking about her child and her telling me about what they were doing. We didn't even talk about her mom. This was a conversation between two mothers and having that connection. And I will say the outcome of that conversation was she took her mom home on hospice the next week and did so with peace and comfort and knowing that that was the right decision. But that was the moment that I realized it's okay to let people see that you're human. And since shifting that mindset of, we don't need to share everything all the time, but
Right.
it's
There's
okay to let
discretion, right?
people,
There's a little bit of discernment that you have to have there, right?
right? But my whole mindset changed in that moment of it's okay to let people see me as a human and me as authentic. And since then, it's amazing that they just tell you things and then they'll get to the end of the conversation and they're like, I don't know why I just told you that. And like, keep going if that's what you need to talk about. If that's, what you need to make these decisions, then I'm glad you feel safe enough to do that.
So then you transition into as a provider on a one-to-one, and then you kind of go one to many in the sense that you're now overseeing populations of patients. What was that transition like for you?
So we had what was called clinical advisor role. So like I said, I ended every day saying, this is the best job ever. I don't know why anybody would not want to do that job. And I guess that passion was seen by the powers that be. And so I became the clinical advisor for a team of nurse practitioners. And in that role, it was educating them and training them and working with them one-on-one to learn how to have these conversations, helping with medical management. So I did that for about a year. And then we had a clinical manager position open on another team. And I was asked to lead this team, which was a very unique experience because everybody had 12 nurse practitioners, 12 absolutely phenomenal women that I will always hold them dearly. Some of them still work for me because they made such an impact on me that, but all of them were brand new to the company. And so they had all started new. Some of them hadn't been practicing very long. This is my first time really, truly leading a team of people. And I assumed this team in March of 2020. If you see that on my resume, well, if we all remember what happened 4 years ago, I had all these grand plans of I'm going to spend so much time with them and meet them, and I'm going to be there with them. And I met them all one time, and then we were shut down. And that's when COVID hit, and we were locked down. And I had to get really creative with how do I coach this team and how do I lead this team? And then very, very quickly it shifted to, we were in long-term care. When COVID hit the long-term care communities, it was bad everywhere. It was bad in every setting. But it was, I woke up every morning to find out how many of our members had died the night before. And I had nurse practitioners calling me in tears because it's like we didn't know what to do. We didn't know how to treat it. And it was the most helpless that we had felt as medical providers. And I'll be very honest, I think the hardest part was that families weren't allowed to come into the facilities. And so not only were we dealing with this, but we were the only people sometimes that our residents were seeing. The nurses in the facilities were, half of them were out because they had COVID or they had children out of school and they couldn't work. And it just,
Right.
it suddenly became not even about strategy. It was about we are humans and we are all surviving this. And I have got to lead this team of people who are, we're all learning as we go. And had I not developed that ability to be human, I don't think I would have survived that. And I think they trusted me to lead them through that because I didn't mind if they called me on the phone crying. And I said, let's just let it out, cry it out so that you don't have to take that home to your family. And we very much bonded during that time.
Amazing. So if you kind of take to what you're doing today,
Mm-hmm.
how much of being human is part of your leadership strategy? And then how do you use that to continue to push the envelope, to continue to innovate? Talk a little bit about that.
So since that time, I've switched. I have come to another company, same product. So we're an institutional special needs plan, um, leading a bigger team, much bigger team. So I came to this team in clinical leadership, progressed, became the clinical director for our market. And it was 100% being human. It was, we have we have KPIs, we have metrics to hit just like everyone else. And I'm very much a numbers person and very analytical. But to get people to buy into that, they have to see that you're passionate about this. This isn't just, it's not just numbers. It's not just, being a profitable company. Of course, every company needs to be profitable to survive. Uh, but being able to convey that passion that I truly do believe in this model. I truly believe in value-based care. It only makes sense for everybody involved. It can only improve quality for our members. And when they see that passion and they see that, they believe it. they they actually think, okay, I get why you're being so hard on us for these numbers and these expectations, because it translates into improved quality and increased access for our members. And so at some point along the way, somebody decided to give me a chance, which I will say, not somebody. I will say I work for Longevity Health Plan, and extremely innovative company, and probably one of their biggest assets as a leadership team and their executive team is they don't mind saying, you might not be on paper what we would have fit for this operational role, but we're going to give you a chance. And so I transitioned over to the operations side, and so that's how I became the operational leader for North Carolina. And it's been interesting bringing that clinical passion over to the operations side.
Right.
And I love having those conversations to say, the money makes sense, the value-based care makes sense, it all makes sense. Let me tell you why. Like, even our operational leaders sometimes, I think, don't realize how much value we really do bring. I think they know it on paper, but it's like,
Well,
let's
what do you think sticks out in terms of the value that you're driving to the members that you're caring for? What's at the top of the pile for you?
the top of the pile, I believe, is truly the care coordination and helping the residents access their benefits, right? So we're a Medicare Advantage plan, which everybody has very polarized opinions on Medicare Advantage plans, depending on where you sit, in the healthcare sector. But we are specially designed for long-term care residents. We have clinicians, nurse practitioners, and physician assistants in every one of our nursing homes. They have very small patient panels. We have account managers. We have member advocates. If one of our members has an issue with a claim or accessing a provider that they need to access, there's times I'm personally handling that issue. Our account managers will go to the building and manage this. I think this population, not even this population, I mean, in health literacy, I've been in healthcare for almost 15 years now, and it's complicated for me sometimes.
Yeah,
I
yeah.
can't imagine what it's like for, long-term care residents and their families to actually understand how to access the benefits that they're entitled to and how to access the care that they need. And that is what sets us apart, is that we have a team of people ensuring that they have access to all of their benefits and all of their care and their informed decisions. Just because you can have the test doesn't mean you should have the test. And we
It's
truly,
very. It sounds like it's very human to human. And I
Mhm.
know that sometimes when you think about innovation, sometimes it just kind of goes to technology. Can you talk about the balance of human interaction, leveraging technology, and how do you find that balance so that you're still you're not losing the human touch?
No, and you can't lose the human touch in healthcare. And I think AI has its place, and we're using it for claims and whatnot. But at the end of the day, we're people, and we're taking care of people. Um, so that, well, and I will say, anytime I have a meeting, I always offer an in-person meeting the first time. Even if I have to fly there, even if I have to drive hours there, I can accomplish more in a 30-minute face-to-face conversation than I can accomplish in, months of emails and virtual meetings. And, it takes understanding that we're all people, we're all here for the same reason. We want to take care of these residents. Like I said, the patient that I had with her daughter, it was like, we need to have this conversation in person. I need you to see that your mother isn't just a member. She's not just somebody on my list, on my roster. She's a human being. I see her every day, and I need you to see that I'm a human being who's trying to do what's in the best interest of your family, and I want to understand you. And, I think, yeah, I don't know how in healthcare we're going to replace humans with technology. I think telemedicine
They
came out of
won't.
COVID, and it
They
was
won't. it won't be
Yeah.
replaced, but how do you augment it? How do you augment it and supplement it? Because as you scale, I guess you start to think about, well, is it possible? When you're managing hundreds, maybe, but thousands and tens of thousands, and then hundreds of thousands of lives. I mean, I don't know. I'm not sure. I'm not sure. I don't have the answer, but maybe you do.
Well, there's a place for it. I mean, sure, in like trends analysis and claims data and things like that. I mean, I love technology and I love reports and I love being able to have access to that. But at the end of the day, when you're taking care of patients, I mean, the answer to that is we need to make it easier to, not easier, it still needs to be quality programs, but we need to ensure that we have the clinicians and we have the workforce that is able to connect with these patients. You're not going to replace clinicians with even telemedicine. Like I said, there's some things you can do by telemedicine, but you know, most of the time, and I'll say I still, even on the operations side, I still never walk into a building without my blood pressure cuff and stethoscope in my bag. Because if I think we can diagnose a clinician that really, is astute, you can tell so much just by putting your hands on a patient and talking to them and looking at them and seeing their body language and sensing them. And there is nothing that technology can replace in that human connection and in those human to human conversations.
Absolutely. You mentioned that you like data and you like statistics. What are your sleep well at night metrics that help you sleep well at night that you look at?
Help me sleep well at night. I'm going to be honest. Most of them keep me up at night if we're being very honest. I mean, I think that
But
is
what
the
are those things
frustrating.
that keep you up? I mean, what are those metrics that you're like, oh, we need to be in line there, but it's not. What are some of those key metrics that you evaluate and you assess regularly?
So that what I evaluate and assess regularly, I mean, we're certainly looking at utilization of care. Are we utilizing care in the right place? The thing that's so unique about long-term care settings is that we can do a lot of the interventions that somebody in the community would have to go to the hospital for. And
Hmm.
so we have
Hmm.
this unique opportunity to treat, and this is their home. We
Right.
call it a long-term care facility, a skilled nursing facility. We call it all of these very, hospital like terms, but this is their home. This is where they live. This is their bed. Most of them will spend the rest of their lives in these facilities. If we could treat them there, then we should. And so when we're seeing patients go to the hospital, knowing that they're being treated by someone who doesn't know this person, they don't know their medical history. And here's where, technology should be playing a really important part in medication reconciliations and drug interactions. And we're missing them still. So it's like we have all this access to technology and we're still not even harnessing it to
But why do they get
improve.
missed? If we have access to the data, why do they get missed?
Because I think that's where we start to depend on it and we assume that it's being done and nobody looks at it. And when you don't know the patient, I mean, we have patients that'll come back from the hospital and they're on two medications in the same drug class. But we depended on that technology to catch that. It didn't catch it, or it did catch it. And we have, the term alarm fatigue in the hospital where you have so many alarms going off, you just tune them all out. And so we're still not harnessing technology to improve patient safety. That's the one place that it could be used. Whereas if they'd have just never left the facility, they just stayed with the provider that knows them, that knows their care, that knows their medications. I mean, I would do medication reconciliations on patients and not even have to look at their former list. I already knew what they were on because I knew them that well. And you can't replace that knowing of them. So that keeps me up at night is still, you know, I, I started this to keep people out of the hospital unnecessarily, and I think we're making a dent in it. Everyone that we keep where they are and treat them in place was worth it. We still have a long ways to go, for sure, in ensuring that these patients have access to the correct care in the right place and by the right person.
If there's anything that you think you could sort of change to make significant improvement? Have you kind of put your finger on what that could be?
Really buy-in of the whole medical community. Like I said, I think we're so, unfortunately, I think we could polarize about anything right now. If I asked you what your favorite food was, I think we could argue about it. I mean, and that's where we are, is that
Yeah.
everything is black and white and so polarized, and this is the way we've always done it. And I mean, I've had two of those conversations this week with, different nursing home operators and staff, that it's like, I get on paper it makes sense, but that's not the way we've always done it. And it's just such a hard buy-in to get everybody to understand that the value-based reimbursement, value-based care really does, like, it improves the financial state of the facilities, it reduces unnecessary medical expenses, and it ensures that the patients are receiving the care that they need. It is completely a win-win-win, but it's such a paradigm shift that said I was a provider, on the practitioner on the fee for service world. I get it. The more patients you see, the more you bill for. That's how you make money. We're not there anymore. It doesn't work anymore. But it's a huge paradigm shift, and people don't like to be told that the way that they've thought their whole career might not be right. And so getting that mindset to shift is very difficult.
I think the answer lies in your story. When you mentioned about things being black and white and how you were very black and white, and that inflection point that came where you then sort of made that shift. The shift to me wasn't a huge shift. It was just a 2 millimeter shift, but it was very, very big implications. It seems like that's kind of where we're at on a larger scale. And the amount of enthusiasm and passion that you have for the value-based care, especially with some of these other, not just ones on your team, but other folks that are in this ecosystem that also are involved in this, that same level of passion and enthusiasm, like it's got to spread to them too. And they got to know who you are and you got to know who they are. And then I think inherently when there's a little bit more of that relationship equity, which is really what we've been kind of talking about, that allows for more of these more meaningful conversations to occur where I think changes can happen and happen rapidly and at scale. But yeah, it's your story has been it's really fascinating to sort of see it. So I'm just looking at it from someone on the other side of the screen. But yeah, I think there's a lot of parallels to your story and then what's happening at scale.
Well, I
What
appreciate
else?
that. I never thought I would
I
end
mean,
up here. I've learned to, when an opportunity presents itself, just to say yes. And it's worked out very well for me.
so how can people follow you, your work, the work of Longevity Health Plan? Maybe just kind of just do like as we kind of wrap our time here, it's like a little 60-second commercial of how people can follow what you guys are doing.
Yeah, so I am on LinkedIn. I do like to share on LinkedIn the great things that we're doing. I said, I think we're extremely innovative. I love that, if we see a need, if we see a way that we can serve our members better, then we do that. And, one example that we have that we love to post on our Longevity Health LinkedIn page, we realized that we had these great supplemental benefits that the residents were struggling to navigate. And so we created what we call a member advocate role. And they're not clinical, and they're not even, I don't want to, they're not keeping patients out of the hospital like our nurse practitioners are. Like, I don't want to say that they don't have a financial value, because they do. Their whole purpose is just to be there for the member and to walk them through accessing their benefits and to help them ensure that they are really taking advantage of everything. And I love that every single time that we say, hey, this is a need that's not being met that could improve the lives of our members, we immediately convene to say, then how do we fix it? What do we need to do to innovate and create it? So if you go on our plan, you'll see some wonderful pictures of our member advocate team. We probably highlight them more than anybody, just because I think that social interaction and the impact that we make on our members extends so far beyond their physical health. So I'm very, very proud to work here.
Incredibles. And if you had to have someone maybe take one thing from what you've shared today and take action on it, what's that one thing that you would have them do?
Honestly, it's to lead with authenticity and if you're not in a people leader role, that everybody is in a leadership role. Somebody is looking at you, whether you realize it or not. Somebody is looking for your passion and your humanity. And I, that's it. That's to bring authenticity to whatever it is that you're doing, whatever role you play, just to bring your whole self there and all of your passion there, and remember why it is that you're there. And it is contagious, whether you realize people are looking at you or not. Authenticity is contagious.
We're gonna have to end with that because authenticity is absolutely contagious, and you've been super authentic. So for those that have tuned in, if you found this conversation to be enlightening, helpful, certainly was authentic, please, would you mind sharing it? Would you mind commenting on it? Maybe even just indicating what are some of the things that you found profound? What are you going to do? What are you actually going to implement? Because at the end of the day, it's not just about sitting around and listening. It's about doing, taking action. So Bridgette, great to have you on. Looking forward to our next conversation, and thanks again.
Thank you, Michael, so much.